also, I would like to thank Sanofi for sponsoring this event. Our talk today will be in two parts. The first part, I will present it. It's 15 minutes about the unmet needs in relapsed refractory multiple myeloma. And the second part by Dr. Majid about monoclonal antibodies. I'm going to introduce Dr. Majid later. I would like to ask the participant to type their questions in the Q&A button there, and to everybody to keep their microphone muted. Once again, thank you for Sanofi for sponsoring this event. Okay. Now I'll start my talk about the unmet need in relapsed refractory multiple myeloma. This is a very complex topic because despite of the progression in myeloma management, we have now over the last 10 years, more than 30 FDA approved novel agents for myeloma. And this is more than any other hematological malignancies. Still, there are some categories of patients that are difficult to treat, including relapsed refractory multiple myeloma, multi-drug resistant patients, high-risk patients, elderly and frail, renal failure patients, and some niches such as plasma cell leukemia and CNS myeloma that are beyond my talk today. How about the unmet needs for relapsed refractory and high-risk patients? Despite the introduction of targeted therapies and triplet combination regimen, patients continue to experience multiple relapse. It is estimated that 48 to 66% of all treated myeloma patients are relapse refractory. This is a natural progression of myeloma from umgus or smoldering myeloma to active myeloma, and then remission, then relapse, second remission. So whenever we go through lines of therapy, the duration of remission shortens progressively. And what adds to this poor outcome is those who are refractory to IMiDs or proteasome inhibitors, high cytogenetic risk, especially the high burden 17B deletion, renal impairment, and age. What adds to the complexity of management of such patients that the myeloma patient that you treat today is not the same patient that you treat upon relapse after 7 days or 7 years or 10 years. Patients get more older, more frail, their number of comorbidities will increase, their ability to withstand treatment-related toxicity might decrease, the number of cytogenetic abnormalities may increase, and also they develop resistance to specific drug. They might develop resistance to specific drug. All those factors will reduce the number of treatment options available for those patients. This is one of the largest trials done in myeloma. It's done in around 5,000 patients from multi-center in United Kingdom and Europe. They look at the median treatment-free survival, as well as the complete remission rate and the depth of remission along the lines of therapy. So as you see, whenever you proceed through lines of therapy, the duration of treatment-free survival will shorten. For instance, from 10 months after the first line to only 1 month after the five line. Also, the proportion of patients achieving a complete response will decrease from 32% in line 1 to 2% only in line 5, and also the depth of remission identified by the very good partial remission. So at least, 74% of the patients achieved at least very good partial remission after line 1, while only 11% achieve it after line 5 and beyond. Also, trials showed that there are poor outcomes with successive treatment in regard to overall survival and duration of remission. So the overall survival reduced with each line of treatment. Here above the curve is line 1, and here the inferior outcome for line 4, and more down. As well as the duration of remission will shorten progressively. So from all those trials that we mentioned, and there are more trials in that regard, the point here is that the most important remission is our first remission. I will go back to that slide. Our first remission. So we need to work on the first remission because it's the most durable remission, and we need to maybe in the future to involve more potent agents to make the remission more durable and the MRD more deeper. There is another difficult group to treat. Those are the lenalidomide refractory patients because they represent a high unmet need in myeloma. So trials showed that patients who are lenalidomide refractory to the first line, when they present in second line, they usually have shorter progression-free survival as compared to patients who were lenalidomide sensitive, and also they have higher disease burden. Also, another group is the high-risk cytogenetic, especially deletion 17p. However, trial showed that triplet is better than doublet, as here in the right of the table. There are some trials. Still, the outcome is not optimal, and still is not comparable to the standard risk myeloma. Also, there are ongoing trials with quadruplet versus doublet in high-risk cytogenetic patients who are young, of course, to tolerate this for drugs treatment regimen, including the Griffin trial, which include daratumumab versus daratumumab VRD versus VRD, and there are positive results from these trials in favor of the quadruplet. However, we still don't know the final because we don't have the results from phase 3 yet. We need to wait and see. And more clinical trials are required to meet the needs for this category of patients. Hopefully, with the rapid evolution in myeloma therapy, with all the agents that we have, and with the coming agent, including the bispecific antibodies, the monoclonal antibodies, the CAR-Ts, and the drug conjugate, maybe the outcome for this group of patients will be better. Now I will move to another unmet need in multiple myeloma. Those are the elderly, frail multiple myeloma patients. And we know that 2/3 at least of myeloma patients are elderly. And the introduction of new agents have been reported to prolong survival in elderly patients. The age itself should not be an obstacle to treat myeloma. However, frail patients were found to have more treatment-related adverse events, leading to shorter survival. Palumbo in 2015 came with the International Myeloma Work Group Frailty Score, where he incorporated 3 factors, including the age, the cognitive and physical function, as well as the comorbidities. And he came with a score from 0 to 5, where 0 means fit patient, 1 intermediate, 2 or more are frail patients. Also, Palumbo showed in the same trial that frail patients did worse when it comes to overall survival and progression-free survival than the intermediate and fit patients. Also, he showed that frail patients has more grade 3 and 4 non-hematological toxicities, as well more chance to withdraw treatment or discontinue treatment for frail patients. If you see, there is no much difference between the intermediate and fit patients in the outcome. That's why some trial only divided the patients of myeloma to frail versus not frail. So if you summarize the unmet need for elderly frail patients, elderly and frail patients have challenging characteristics that can impact treatment. The International Myeloma Work Group recommend that physicians who are treating myeloma to incorporate the frailty score during their clinical evaluation for their patients to aid the choice of treatment and balance toxicity versus the quality of life and survival. There is need for clinical trial tailored on frail patients, and we know that most of the clinical trial will exclude frail patients, so that's why we don't know what's optimal for them based on clinical evidence. Treatment options for elderly frail may be reduced due to toxicity, and there is a need for new, less toxic, easily administered therapies. Also, sometimes, we can give the doublet rather than triplet. However, we should not consider palliative as a defeat, because palliation is always an option when you are encountered with a very frail patient who cannot tolerate whatever option you have. Another unmet need in relapse refractory multiple myeloma is renal failure. You know that renal failure is a common manifestation of myeloma, whether at presentation or upon relapse. Bortezomib is an appropriate option for patients with relapse refractory multiple myeloma who have renal failure. However, when you have refractory to bortezomib inhibitor, this is a limitation, but the good news that we have new approved agents that could be an option in renal failure and multiple myeloma. Some of the new agents will need modification and some will not need modification. But still, we need more clinical trials in myeloma, same as the story for frail patients. Most of the clinical trials will exclude renal failure or severe renal failure, and that's why we need clinical trials tailored on renal failure myeloma patients to see what's optimal for them. The last point that I will talk about is the unmet need in multiple in MRD patients. This is an area that has a lot of talks nowadays. And we know that MRD, which is the presence of residual malignant plasma cells after completion of therapy, has an outcome had a very big impact on the outcome of myeloma. And the International Myeloma Work Group now had modified its categories to incorporate MRD within the response criteria for multiple myeloma. We know that the deeper response that we have and the more negative the MRD is, better the outcome when it comes to PFS and overall survival. There are many trials that compared MRD positive myeloma patients to MRD negative myeloma patient, and there was significant improvement for, there was significant favor for MRD negative than MRD positive when it comes to PFS and overall survival. We don't have results from trials tailored mainly on MRD as a surrogate point, but we have many ongoing trials with MRD at endpoint, including the new medication Istoxmap and also the daratumumab. So we will wait for the result from these trials. We have, these are the methods to detect MRD. I will not go through that, but the most important are the next-gen flow cytometry and next-generation sequencing. There are other methods like PET and so on. But still, if we want to summarize the unmet need of MRD, we know in myeloma that MRD has an important role in relapse course of myeloma. Achieving MRD negativity is very important, but currently there is no clear cutoff when to check the MRD, how to act if you find an MRD positive. Hopefully in the future we'll have clear guidelines for this one, and we'll have a medication that will act on MRD, same as the story of LINA Termimab in acute lymphoblastic leukemia. So there are many key upcoming phase 3 studies, including MRD status as an endpoint. To conclude my talk, despite the progression in management of multiple myeloma, there are still unmet need for some patients categories, such as refractory elderly frail, high-risk patients, comorbidities, and plasma cell leukemia and CNS myeloma. And with the rapid development of targeting agents, including monoclonal antibodies, drug conjugate, bispecific antibodies, and CAR-T, hopefully some of those needs will be met. MRD eradication is another unmet area that should be fully addressed. I think I will leave the questions and answers for the end. And now I'm going to, it's my pleasure to introduce the next speaker, Dr. Majid Al-Ahmari. Dr. Majid is a consultant adult hematology and bone marrow transplant at Princess Noura Oncology Center in the Western King Abdulaziz Medical City, Western region. He is also an assistant professor at King Saud University, Jeddah. He will talk about the updates in myeloma management with a focus on monoclonal antibodies. Dr. Majid, the floor is yours.
Okay, thanks, Dr. Hind, for the nice introduction. Assalamu alaikum and good evening, everyone. I want to thank SSBMT for the invitation, and also want to thank the sponsoring companies. Can you see my slide?
Yeah. Yes.
Excellent. Okay, so the talk of Dr. Hind was a very nice introduction for my talk. So what's the latest in multiple myeloma? So as Dr. Hind mentioned earlier, that there is a huge unmet need in multiple myeloma, since we all know that this is incurable disease. And with every subsequent relapse, usually the remission does not last as long as the one before. And we all know that the first remission is the longest remission. So we all know that with our patients and their journey, at the end, we always have that difficult time when we say, sorry, we don't have much to offer. And this is a very heartbreaking end for a patient journey that you are working with him or with her for a number of years. So every new class of therapy is considered as a bright hope for these patients and for their treating physicians. So we hope with time we would have more. And we all know that the prognosis of multiple myeloma now is much better than what it was before. And all of that is related to the development and if the improvement in the way of therapy and also the way of the diagnosis and risk stratification. So and this is mainly related to the idea of the clonal tiding, that multiple myeloma is not one disease. And if you look at the plasma cells, they are not only one clone. They have different genetic structure, and usually there is one that's dominant that responds to your first line therapy, but then at the relapse, you might have a different clone with different drug sensitivity as well. Today I'm gonna just go over some updates from 2020 from EHA, ASCO, and ASH. Some of the abstracts that I'm gonna present are new. Some of them have been presented before, but this is just an update for them. So I'm gonna talk about some of the data that's been presented recently about Istoxmap. So Istoxmap is a monoclonal antibody against CD38, which fights myeloma cells through different mechanisms. It activates the natural killer, so that will lead to antibody-dependent cellular cytotoxicity, and also activate the monocytes, macrophages, and that will lead to antibody-dependent cellular phagocytosis. And also through the complement, it can lead to complement-related death for the myeloma cells, and also direct killing effect with apoptosis. So the CARIA trial basically looked at patients who are relapsed refractory, who had 2 or more lines of therapy previously, and they accepted the creatinine clearance up to 30 with no prior exposure to pomellitamide. Patients were randomized to receive either Istoxmap PomDex or PomDex only, and the primary endpoint were PFS over response rate and duration of response. So basically, this is how the drugs were administered. So for the first cycle, you would give Istoxmap weekly and pomellitamide with the usual protocol, 4 milligram day 1 to 21, 1 week off, and dexamethasone weekly. From cycle 2 and ahead, Istoxmap would be given every other week, so day 1 and day 15, and PomDex will continue the same thing. So these are the characteristics of the patients. So basically, they are heavily treated. So basically, we're looking at almost all of them were LINA refractory, and almost all of them were refractory to the last line of therapy. About 3/4 were double refractory, which is the group of patients that we usually suffer with, IMiD and PI refractory. So the PFS was better in the Istoxmap PomDex arm, so 11.5 months versus 6.4 months with a significant p-value. And this significant difference was noted in all the subgroup analysis, so including high-risk cytogenetics patients who are LINA refractory as well. In terms of the overall response rate, so patients who received Istoxmap PomDex had a better response with a response rate of 60% versus 35%. And also they had a deeper responses in terms of MRD negativity, so 5.2% versus 0%. So far, there was no significant survival benefit, but there was a hint of a better survival with the Istoxmap Pomdex arm, but that was not significant yet. So in terms of the safety, so there was, as everyone know, with monoclonal antibody, there is infusion reaction. So grade 3 or more were 2.6%. And also there was an increased risk of toxicities usually related to that group of drug, mainly upper respiratory tract infection, bronchitis, pneumonia. In terms of the hematological toxicity, there was increased risk of neutropenia, so 60% versus 31%, as we can see. So there was a subgroup analysis that was updated in the most recent ASH about this trial. So the frail patients, and as Dr. Hind mentioned earlier, that's a huge unmet need in that group of patients. What to do with the frail patients? So basically, in that group of patients, the addition of Istoxmap Pomdex resulted in a better PFS, so 9 months versus 4.5, so double. And that was not associated with a safety signal. So the drugs were quite tolerable, and addition of Istoxmap to backbone Pomdex did not result in safety signals. The second trial is the IKEMA trial, which was presented in EHA, updated in EHA last year. So Istoxmap, carfilzomib, and dexamethasone versus carfilzomib dex. So they were looking at patients with relapsed refractory myeloma with one or more lines of one or more lines of therapy previously, included more than 300 patients. And they were randomized in 3-2 format to either ISA KD versus KD. So they used the biweekly carfilzomib dosing in this trial. So 56 milligram days 1, 2, 8, 9, 15, 16. Istoxmap was given on the usual protocol. In the first cycle, you would give it weekly, and then subsequently you will give it on day 1 and 15. Dexamethasone was given on the usual protocol. These are the basic characteristic of the cohort. And you can see that there is about a quarter of patients were high-risk cytogenetics. Half of them were IMiD refractory, and about a third of them were PI refractory as well. So after a median follow-up of about 2 years, the PFS in the ISA KD was not reached, where it was 19 months in the KD arm. And that was also noted in almost all the subgroup analysis we can see here in favor of ISA KD. In terms of the depth of the response, so there was a slight improvement of the response rate in the ISA KD arm, but there was a significant improvement in the MRD negativity, so 29 versus 13% in the KD arm. So same thing, survival, as we know from most of the myeloma trial, survival does not be manifested until after long follow-up. There was no significant difference in the survival between the two arms. In terms of the safety, there was no difference in the serious adverse events between the two groups, as well as the fatal adverse events. In terms of infusion reaction, so one patient had a grade 3 or more of infusion reaction. In terms of cardiac toxicity, which is an interest for us, especially when we're dealing with carfilzomib, Addition of Istoxmap to the backbone of KD did not result in worsening the cardiac event. So this is an interesting poster which was presented in most recent ASH by the MD Anderson group. So they looked at a question that we might ask ourselves. So what's going to happen if we introduced Istoxmap in someone who previously exposed to daratumumab? And so they tried to answer this question in this poster, and they found that in the group of patients who previously exposed to DARA, there was actually a 53% response of PR in that group of patients, which for me sounds interesting. So that could be something to work on in the future. So another monoclonal antibody we're all familiar with, daratumumab. So the Apollo trial, which was presented in the most recent ASH. So it's a phase 3 randomized study looking at subcutaneous daratumumab, PomDex versus PomDex alone in relapsed refractory myeloma patients with one or more previous line of therapy. So the number of lines, a median of 2 in both group, LIN refractory in about 3/4 or more, double refractory on almost half of the patients. So this is patients who are they're refractory and they're difficult to treat. High-risk cytogenetics were about a third of the patients. So in terms of the PFS, so it was 12.4 versus 6.9 months in favor of Dara PomDex. And that's overall, but it was the case in the different subgroup as well in favoring Dara PomDex. In terms of the response rate, so the response to Dara PomDex was 69 versus 46%. With MRD negativity was noted in 9% versus only 2% in the PomDex arm. In terms of the safety, this combination was not associated with severe infusion reaction since it's a subcutaneous and well tolerated. So no patient had infusion reaction of 3 or more. The other abstract that also was updated in the most recent ASH was the Condor study, and I'm sure most of you are familiar with this trial. So basically, looking at relapsed refractory myeloma patients who received more than one line of therapy previously, and they were randomized to receive either Dara KD versus KD, and they're looking at PFS. So same thing, this is a group of patients who were heavily treated before. Most of them were exposed to lenalidomide or bortezomib. So in term, based on the updated results, so the PFS in the DARA KD was 28 months versus 15.2 months. And that was noted in all the subgroups. So the high risk also DARA KD was 15.6 months versus 5.6, and patients who are LIN refractory, which is difficult group to deal with, 28 versus 11.1 months. In terms of the safety, so grade 3 or more was comparable in both arms. Fatal effect was more in the DARA KD, and I think based on the initial presentation, it was mainly related to infections, mainly pneumonias. So basically, this trial showed the superiority of DARA KD in a group of patients who are difficult to treat. The other trial, which was also updated in the most recent ASH, was the Griffin trial. So just to refresh your memory, so it was for newly diagnosed myeloma patients were randomized to receive either induction of DARA, RVD, or RVD, which is the standard of care. Then everyone got a transplant, then consolidation of DARA, RVD, or RVD based on the arm of stratification. Then maintenance of DARA RD for 20 months versus lenalidomide for 24 months only. So the results are a bit interesting, and we can see that in terms of the depth of the response, addition of DARA to backbone of RVD resulted in a deeper response, and mainly in terms of MRD negativity. So the sustained MRD negativity for more than 12 months was significantly better in the DARA RVD versus RVD. That still did not translate it into a clinical significance. So the PFS was and the overall survival was were comparable, but this is still premature to judge, and I think we'll wait for more updated results about that. So the new class of therapy, and this might be a new hope for myeloma patients. So BiTEs and anti-BCMA. So the LINA Termimab. So this is actually a very interesting drug, and I think in the future we will have an impact, an important role for this drug in the myeloma therapy. So basically, it works in a unique way. So it's a antibody drug conjugate. Okay, if as an example like Istoxmap. So basically, it's bind to the BCMA and lead to lysosome, it will be engulfed in the cell, and eventually leading to apoptosis. On the other side, also, it's a bispecific antibody T cell engager. So basically, it engages the T cells to the plasma cells, leading to cell death. So, in the ASCO of the last year, the DREAM trial, which was presented and led to the FDA approval of this drug. So basically, they looked at a very tough group of patients to treat. Relapsed refractory myeloma patients with 3 or more previous lines of therapy, and they randomized to 2 different drug concentration based on the initial phase 1 trial about the maximum tolerated dose. So basically, they randomized the patient to receive either 2.5 milligram per kilo every 3 weeks, or 3.4 milligram every 3 weeks. And the primary outcomes was overall response rate, but also they were looking at other outcomes like duration of response and PFS. So a very difficult, tough group of patients to treat. So basically, in their analysis, they found that this drug has efficacy clearly. So the overall response rate in that difficult to treat group of patients were about third. So third of the patient, they have achieved response, and actually not a minor number achieved a very deep response up to CR or VGPR. In terms of the duration of response, so in the 2.5 milligram cohort was 11 months versus 6.2 in the 3.4 months, meaning that the higher dose did not translate into a clinical efficacy. And the PFS was short, 2.8, but remember, this is just monotherapy versus 3.9 months. The median overall survival was 14.9 months in the 2.5 cohort and 14 months in the 3.4 cohort. Serious adverse events were noted in about 40% of the patients. There was 2 that's happened. They seemed to be therapy related. One of them was sepsis, and one of them was due to HLH. One of the interesting adverse events happening with this drug is keratopathy. So, it's a standard of care when you're treating, when you're using this patients, you have to use eye drops, steroids every 6 hours for 4 days after administering the drug, trying to reduce the keratopathy risk. So, that DREAM2 trial was for single agent pomellitamide. So what about if we use it as a triplet? So in this paper, or this abstract was presented in EHA by Dr. Trudel, using a triplet. So pomellitamide plus Pom-Dex, using different drug concentration. And they are also looking at a group of patients who are difficult to treat, so 3 or more lines of therapy. Most of them are refractory to all known lines of therapy, LEN, PI, daratumumab. And they found that the response rate is very great. A small number of patients, but very promising combination. So 86% they have achieved response. Most of them actually were VGPR or better. These are the adverse events, and you can see here the keratopathy. It's common to be happening with this drug. So this was updated in ASH, and still the results are quite promising. So overall response rate of 100%, VGPR of more than 72%, quite promising. And if we want to look at the PFS, so it was not reached in all patients, and even in the patients who are IMiD PI refractory, or in the but in the triple refractory IMiD PI DARA refractory, which is, I think, the most difficult group of patients. The PFS was 11.1 months. That's for that group of patients. I think that's something. So another BITE was also presented in ASH as updated results. So the REGN 5458, the BCMA CD3 bispecific monoclonal antibody, and relapsed refractory multiple myeloma. So same thing, looking at a very difficult group of patients to treat, more than 3 lines of therapy, refractory to all the known drug classes that we use. And in terms of the responses are promising. So in the stream 6 with drug concentration, more than half of the patient, they achieved a response. And from the responder, lots of them, they had very deep responses. And in terms of the tolerability, so there was, when we are dealing with BITEs, we are concerned about neurotoxicities. There was no neurotoxicity reported with this new BITE. And in terms of the CRS, there was no reported severe CRS. Another BITE, the Istoxmap, difficult name. So same idea to the previous one. And same group of patients, difficult to treat, refractory group of patients. So, and we can see here the median number of lines of the previous line were 6 or 5. So difficult group of patients, and quite promising in terms of responses. So 3/4 of the patients have achieved responses. Lots of them were deep responses as well. We will need a longer follow-up to know about the safety and also the duration of response for that drug. The selinexor is a nuclear exporter inhibitor, which showed efficacy as a single agent and also in combination. So in the STORM trial, or the STORM trial, which was also updated in the most recent ASH. So basically, a difficult group of patients with myeloma with quite refractory disease. Median line of previous therapy were 3. So, the maximum tolerated dose that they have choose was 60 milligram weekly, plus the POM4 and XF40. And for that concentration, the overall response was 60%. with significant hematological toxicity, since we know that can happen with POMDEX. So in term of the PFS, so still it's not a long follow-up, but after about a year or more, the PFS was not reached in the concentration of the 60 milligram, and for the POM naive non-refractory, it was 12.3 months. So I think maybe this is the last abstract that I have for you. So this is actually another unmet need, and Dr. Hind mentioned that in her presentation, the frail patients. What to do with these group of patients? So, so this is actually the frailest. So most of the patients were enrolled in this trial were 80 or older, with very advanced Charlson score. So basically, patients were a newly diagnosed myeloma treated with a gentle induction, I would say, Ixazomib, daratumumab, and low-dose dexamethasone. And basically, we're looking at two things here: efficacy and safety. So in terms of efficacy, so overall response rate were 78%, about 35 patients were VGPR or better. In terms of the PFS was 13.8 months, and survival was median overall survival was not reached. And if you look at the toxicities were quite acceptable, especially if we are talking about the patients who are really, really frail. So very manageable toxicities, and even discontinuation rate was not that high, despite the patients were enrolled in this trial. So I think that's what I have for you, and I would be more than happy to take any more any questions. Thank you.
Okay, thank you, Dr. Majid, for this very elegant presentation. I will look at I can't see any question in the Q&A box. Meanwhile, I will just ask you one question. How do you see, Dr. Majid, with all what we said, that the first remission is the most important remission? How do you see the future of these novel new agents, the monoclonal antibodies, as first line, especially in fit patients, in order to deepen the response?
Yeah, so that's a great question, and I think that's part of it coming also from the results that we know. The Maya trial showed excellent PFS despite no transplant. So meaning that, you know, enhancing the induction will result in improvement of the outcomes, and maybe in the future we do not need to do transplant for everyone. Maybe if we have a better risk stratification, like selecting patients who did not achieve MRD, for example, to take them for transplant. Also, improvement of the maintenance therapy. We have seen on the Griffin trial that with Dara-Len maintenance, lots and lots of patients, they have deeper responses, and even they maintained it. So that might be a new goal and might be a new future for myeloma. And maybe we'll reach to a point that conventional chemotherapy alkylators would not be part of the therapy for myeloma at all. And also, I think the cellular therapy, and I think the cellular therapy is showing a good responses, but maybe we need to move it a little bit to the front. And this is the case with all of the other drugs. For example, bortezomib and lenalidomide in the old days were part of the patient, part of their therapy for relapse setting, but now we are using it in the upfront. So everything is moving to the front, and the idea is to improve the upfront therapy, because the patient's condition at the presentation would be the best. The patient is younger and can tolerate more therapy. So this is actually the chance where you can give most of the active therapy in it.
Okay. Okay. I still cannot see any questions in the Q&A, but this is a question from Dr. Alasker. He had a problem with his microphone. In view of the number to you, Dr. Majid, in view of the number of novel agents coming, it would be challenging to put them in an algorithmic approach. What do you think?
Actually, that's good. The more therapy we have, the better, because there is no one size that fits everyone. So we have to pick and choose based on many things, based on the patient's status, based on the disease status, and all of this. So all of this has to be put in consideration. So I think more drugs, well, for me, talking about myself, will make my life easier, because I do not want to reach to a point where I will say to the patient, sorry, I cannot do anything for you. In terms of how to sequence it, I don't think there is no standard approach, and I don't think there will be any. Just more than one choice, okay, and you pick and choose based on what you have in your center. But I think you have to tailor therapy for each patient individually.
There is another question also from Dr. Ahmed Alasker. It's interesting that the two anti-CD38 antibodies can be utilized after each other. Any comments?
Okay, so the missing point in that trial, which I'm not sure about, if they were DARA refractory or not. So they did not mention that. Okay, so that's if they were DARA refractory and then Istoxmap was given and showed efficacy, okay, that would be interesting. And although they are both CD38, but they work in a bit of a different way, and I think part of it also related to the efficiency of these antibodies or the affinity of these antibodies to the CD38. So it would be interesting to know if that group of patients were DARA refractory or not, which I don't have, to tell you the truth.
We have more questions now. Some people are typing. So DARA medication make it difficult to find compatible blood. How is that from patient's care view to give incompatible blood?
Okay, so yeah, so this is a well-known problem, and so yeah, the recommendation is you have to do a group and typing before commencing your patients to daratumumab, because yeah, it would be might be difficult to do a proper group and screen on a patient after using daratumumab, and that's related to the suppression of the CD38 on some of the RBCs, so will make the indirect Coombs test difficult to be done. So it's the recommendation is you have to do group and screen before starting daratumumab, and maybe you need to do the whole phenotype to know exactly the phenotype of the patients before commencing the therapy.
The other question is from Dr. Ihab Al-Hamidi. Do we have data on the use of isotopesmap in amyloid patients? Did you pass through any, Majid?
Not aware of that. Well, we know that there is a good data on daratumumab and amyloidosis, so it's a very, very effective. And now it was outside the scope of this talk. It was about multiple myeloma, but also in the most recent ASH, there was a presentation on using daratumumab in the upfront setting in newly diagnosed AL amyloidosis, so DARA VCD, and showed excellent results, very deep responses. So I would think Istoxmap might do the same, but you can give me a feedback about that. I'm not aware of any.
I'm not aware also, it's just
Any
recently
study.
approved, right?
Yeah,
Recently
exactly.
approved.
But
Maybe
you know, thinking about it, you will not see something opposing this. Okay, but we don't have evidence so far.
And also we'll take this last question from Dr. Ihab also. Do you think that combination of Istoxmap is better with carfilzomib or pomellitamide?
Okay, that's the $1,000,000 question. Oh, thank you for putting me in that corner. Well, so the results are comparable. The you know the daratumumab now it's subcutaneous. Okay, so that's an advantage, I would say. Okay, it's given in over 5 minutes with zero adverse or serious reactions. So that would be definitely an advantage for that. In terms of efficacy, so the renal. So for the Candor trial, there was significant renal impairment. There was significant infections. So here, there was nothing reported like that. So I think they are comparable, okay? But with the presence of the subcutaneous DARA in hand, okay, the infusion reaction is better, and also the drug administration would be faster. That's how I would think about it.
I would go, if I have to choose, I would go with pomalidomide because it's oral. I don't like to give two parenteral types of chemotherapy. And it will be also patient choice. If the patient had cardiac risk, will avoid the carfilzomib.
And monoclonal antibodies has showed a great synergistic effect when it's given with IMiDs rather than PIs.
I think this is the last question. Anybody has any comment? This is the last question for today. Before we conclude, once again, we would like to thank the sponsors for this event today, Sanofi, and I would like again to thank Dr. Ahmed Al-Askar and the SSBMT for this weekly useful webinar. And I would like to remind you also for the next week webinar, it will be on 13th of March 2020, also continuation of our myeloma session. It's about frontline management of myeloma for transplant eligible and transplant non-eligible by Dr. Ihab Hameda and Professor Maria Victoria. Hopefully we'll see you again next week. Thank you so much.
Thank you.
Thank you, Dr. Majid.